Hi, I'm Amy Reyes. This week from Rheumatology Network, we highlight a study from the Lancet Rheumatology that shows there is little value in repeating anti-nuclear antibody tests. These diagnostic tests are conducted in patients who have inflammatory or musculoskeletal symptoms that may suggest an autoimmune condition, such as lupus. However, the presence of these anti-nuclear antibodies does not necessarily indicate the presence of disease. For more information about this study, visit rheumatologynetwork.com. And this week, we highlighted a couple of new drug approvals for the US market, including Julio. This is the sixth biosimilar to Humira, which will be made available in 2023 for rheumatoid arthritis, psoriatic arthritis, psoriasis, juvenile arthritis, and other conditions. And the FDA also approved Ilaris for adult onset Still's disease, which is a rare form of juvenile arthritis presenting in adulthood. It is the first treatment for the condition. And the IL-23 inhibitor, Tremfya, has been approved for moderate to severe psoriatic arthritis. This particular treatment has been shown to improve the signs and symptoms of fatigue associated with the condition. And finally, in today's one-on-one interview, we speak with Dr. Chrstine Anastasiou. She is a rheumatologist with the University of California who recently published a study in Arthritis Care and Research that finds significant improvements in mortality for hospitalized patients in the US with systemic lupus. But she finds there remains a high mortality rate among Blacks and Hispanics with SLE, and now she finds this also applies to Asian-Pacific Islanders with the condition. Welcome, Dr. Anastasiou, to Rheumatology Network.
My name is Chrstine Anastasiou. Thank you for having me. I am a rheumatologist at the University of California, San Francisco, and I perform research in systemic lupus erythematosus, rheumatoid arthritis, and the inflammatory myopathies.
Well, welcome to Rheumatology Network. I appreciate your time today. So we are here to discuss a study that you recently published, and you were the lead author on this study that focused on mortality in lupus. Would you mind summarizing the findings?
Yeah, no problem. So I'll start off with saying that we performed this research study with the goal of answering three questions. First, how has mortality for US hospitalized individuals with SLE changed over a time period which we chose as 2006 to 2016 when compared to the general hospitalized population? Second, did in-hospital mortality risk vary by race and ethnicity? And third, among hospitalized individuals with SLE, what factors were associated with a higher mortality? So these questions are important for multiple reasons. We know that SLE can lead to life-threatening organ damage and premature death, and advances in therapy have decreased the rate of organ damage and mortality for patients with SLE over the past century. However, recent studies evaluating hospital outcomes for patients with SLE are limited. And the most recent multi-year national evaluation of mortality for hospitalized US SLE patients, of which we are aware, was conducted from 1998 to 2002. So we needed a more recent evaluation of the progress that we've had in areas for potential improvement. In addition, most studies evaluating lupus mortality are based on patient cohorts, which are invaluable research tools, but they capture only a relatively small number of total deaths and may not represent the general lupus population. And most prior research also did not investigate whether there were in-hospital mortality differences for patients with SLE based on their race and ethnicity. So we know that race and ethnicity are important in lupus. Previous cohort and population-based studies of SLE mortality have consistently shown increased damage accrual and mortality among Black patients compared to whites. And most studies also suggested that Hispanic ethnicity was associated with more active SLE and higher mortality. Population-based US studies conducted in the 1970s and 1980s have described mortality rates of 3 to 5 times greater among Asians or Pacific Islanders compared to whites. and a study in the early 1990s showed a higher odds of mortality among hospitalized Asians compared to whites. So this is an important topic as well to include. So we analyzed data from the national inpatient sample, which is also called the nationwide inpatient sample, and it's useful for performing large-scale longitudinal analyses. In 2016, the NIS yielded weighted annual national estimates for more than 35 million hospitalizations, which represents over 97% of US community hospital discharges. So during the study timeframe that we included, there were approximately 1.9 million hospitalizations for adults with a discharge diagnosis of SLE included in our analysis. And our findings were the following. So compared to the general hospitalized population, hospitalized individuals with SLE were younger, they were more likely to be female, Black or Hispanic, live in a low-income area, and they had on average a higher comorbidity index score. And I would say that these characteristics are what we would expect based on prior research. That wasn't anything new. So now let's move on to answering those three questions that I brought up at the beginning. So all-cause yearly inpatient mortality in our adjusted analysis decreased by approximately 30% among admissions for individuals with SLE, from 2.2% in 2006 to 1.5% in 2016. The mortality rate for admitted individuals with SLE started higher than that of the general hospitalized population and decreased between 2006 and 2008. After that time point, the mortality rate for SLE patients were statistically similar to that of the general hospitalized population and remained stable throughout the rest of the years analyzed. We also found that hospitalizations for Blacks, Hispanics, and Asians or Pacific Islanders with SLE were more likely to end in death compared to hospitalizations for people of the same racial or ethnic group without SLE. They were also more likely to end in death compared to hospitalizations for whites with SLE. And interestingly, we found that hospitalized Asians or Pacific Islanders with lupus had a 43% higher risk of death compared to those without SLE, and a 79% higher risk of death compared to hospitalizations for whites with SLE. So in contrast actually, I would say, to what we just discussed for the other racial or ethnic groups, the hospitalizations among whites with SLE were less likely to end in death compared to those without SLE. Mm-hmm. We also performed an analysis to assess factors that are associated with death among lupus hospitalizations. And similar to prior studies, our results showed that men with lupus had a higher risk of in-hospital mortality, and as expected, increasing age and higher comorbidity index score were also associated with a higher mortality. Importantly, though, we found that hospitalizations for SLE patients without insurance were also associated with a higher mortality when compared to those for patients covered by Medicare. So I would say those are all of the main results of our study.
Mm-hmm. So did you examine comorbidities? So in this group of SLE patients, I think you said Blacks, Asians, and Pacific Islanders had a higher incidence of mortality in hospital as compared to the same white population. But did this group have, how did you account for that? Did they have comorbidities that the white patients did not have, or were there any other underlying differences that could explain the higher rate of death?
So comorbidities were evaluated using a comorbidity index score. So we used the Quan modification of the Charlson Comorbidity Index score, which basically sums up multiple different comorbidities into a value that can be used. And so in all of the adjusted analyses, we included comorbidity index score in the analysis. So, um, so what I would say is that that was included in the analysis. So the difference between the outcomes in death among the different racial groups of, Blacks versus whites or Hispanics admitted versus whites would have been accounted in the analysis. And so the difference is not because of the difference in comorbidity, assuming that the comorbidity score captures all of the variation in comorbidity that these groups may have had.
Okay. Well, the results are, alarming. They're not surprising. Like you said, this has been consistent for years. But how would you summarize the results? Why is there this great gap in care between these two groups of patients who have the same disease?
Yeah. So I think the most important takeaway points basically are that one, SLE hospitalizations were more likely to end in death at the beginning of the time frame that we studied, and this mortality rate decreased to a point where over the last few years of the study, it was similar to the general population, and it was remaining relatively stable over time.
Okay.
And the second primary takeaway point, I think, would be that despite advances in overall all-cause mortality among patients with SLE, the US hospitalized Blacks, Hispanics, Asians, they have a higher risk of inpatient death compared to both patients of the same racial and ethnic group without SLE and to whites with SLE.
Mm-hmm. Right. So what would be the next step? Where do we go from here? In your
So
research?
our results suggest that interventions to reduce all-cause in-hospital mortality and interventions that are primarily targeting patients with SLE, such as a broader array of immunosuppressive medications, may have successfully improved in-hospital survival over 1 decade. So that's fantastic news. We also noted that among hospitalized patients with SLE, self-pay status, which means the person did not have insurance, was associated with higher mortality. So future work could potentially investigate whether this higher mortality risk is reproducible, and if so, what are some ways we could intervene? Some hypotheses for why these hospitalizations have worse outcomes could include, for example, limited primary preventive care that may be driving differences in outcomes. Maybe self-pay SLE patients receive a different quality of inpatient care. Or maybe this higher mortality per admission is just a reflection of these patients themselves or their treating physicians having a higher threshold of illness severity for them to be admitted to the hospital compared to individuals who have insurance.
Right.
And then in terms of hospital mortality overall for patients with lupus, I think, these improvements are wonderful. It's great news that we see improvement in the mortality. And the data, though, also suggests that we need to increase our efforts to eliminate racial and ethnic disparities in outcomes through early recognition, treatment, long-term management of the disease. Our research study was the first large-scale population-based study in over 20 years to evaluate US, Asian, or Pacific Islander in-hospital mortality among individuals with SLE. And our results show the importance of considering this population, the US, Asian, and Pacific Islanders with SLE, as at potentially heightened risk for poor outcomes. So future studies should include them when possible. And future studies also may benefit from investigating potential reasons for persistent inequalities and outcomes among all of the racial and ethnic groups that I already discussed.
Right. So in summary, it really speaks to the value of primary care, the importance of early care, an early treatment before it progresses to moderate to severe disease, and the importance of health insurance, obviously. Some way to pay for this care makes a big difference. So to me as a layperson, I think it's eye-opening. I think this is an important study. We look forward to more reports from you. We'll continue to follow your work. I assume that you'll be presenting at ACR this fall. And so we'll be catching up with you then if that's okay.
Thank you so much.
Okay.